that was a series of fantastic talks, and I could listen to Rick and to Irma all day. So and I'm sure you all have lots of questions for them. So I'm going to constrict my talk and actually switch things up and tell you what my goals are, like the take-home points that I want you to kind of capture from the next set of slides up front, so that those don't get missed. And really, I'm hoping that in this next kind of about 12 to 15 minutes, that we drive home the point that in doing implementation research, thinking about fidelity is critical, and how we're going to kind of assess that, how we're going to think about that, both in concrete and abstract ways. Also thinking about tracking adaptations. We're going to kind of talk about that. And then how we choose our outcomes, and when we can really deceive ourselves about whether our intervention is working or not working. So I have 3 case examples. Just one is my work. I found some others that I think display this in a nice way. So I'm just going to quickly try to go through these and give you guys plenty of time for questions for the other speakers. I'm going to ask everyone to stand up and move. We've been sitting for hours, and so let's just do that. And feel free to stay standing as I talk. That's fine with me. So I'm going to start by airing my dirty laundry, I guess, of the very first study that I did that was kind of getting into this space of implementation research. Before I even knew the term implementation science, before I really identified as an implementation scientist, this study actually is what launched my career in the direction that it did, away from being a pure clinician towards doing health services and then implementation research. So, you know, it's Denise, close your eyes, shut your ears. So many methodological problems with this study, but maybe will be a good fuel for conversation. So most of my research now is focused on obesity, but I got my start in research thinking about tobacco, and so how tobacco smoke exposure affects children. So we well know, and it's been so interesting, smoking seems to be quite a public health problem here in Georgia, as I've noticed just walking around. So I've been thinking about this a lot since we landed here, but so short and long-term health consequences of tobacco, I don't need to convince this group that they're of significance. What is troublesome to me and in the US in particular is that we have a high level of inequities and disparities in exposure to tobacco smoke exposure, especially among children. So low-income children are 7 to 10 times more likely to have tobacco smoke exposure than children in higher socioeconomic status groups. Living with a smoker, you're more likely to begin smoking yourself, while earlier parental quitting is associated with, or abstinence is associated with, lower teen smoking rates. And then, you know, as a primary care pediatrician who was in training when I started this project, I was really inspired by the unique role that primary care pediatricians have. There's some really exciting evidence that the birth of a child can be a motivator or a transition point where, you know, whether you believe in the trans-theoretical model or not, in terms of kind of accelerating stage of change, there was some evidence in my literature reviews early on that children can be, you know, a motivating source for parents to move along their stage of change. And so both the National Heart, Lung, Blood Institute and the American Academy of Pediatrics in the US had really stated that pediatricians should be thinking about parents smoking as a mechanism to promote children's health. But despite these sort of national endorsements and guidelines, the national rates of screening, counseling, and referral were very low and continue to sadly be very low among pediatric clinicians, despite really nicely done studies with parents assessing acceptability. So parents were telling us that they think it's totally appropriate for pediatricians to be asking about their smoking status and to be another source of information about cessation. So as a resident in pediatrics, I went forward and did a baseline needs assessment. Didn't know that I was working kind of in the NITEX model of assessing sort of what the baseline needs were. But I just did a simple clinician survey in my own primary care practice. And so I surveyed clinicians trying to use some previously used instruments. And I surveyed 48 clinicians, and 36 of them responded to me. And the majority agreed that tobacco smoke exposure screening, counseling, and referral were appropriate for pediatricians, yet far fewer reported actually screening. And then, even when they were screening, counseling was even less common. And offering referral to what was sort of available options for tobacco smoke exposure among parents was very infrequent. So this is kind of the publication that this work ultimately led to, where we, again, kind of used our electronic health records to try to nudge clinicians to do a better job of screening and brief counseling, and then referring to the state quit line, which was sort of our best available thing or evidence-based practice that we could get to. There's some debate about how effective quit lines are, but at the time it seemed like the best option. So what did we do? We actually just went into our EHR, which looks completely different now, but at the time, this is sort of a screenshot from the EHR where we tried to add in some triggers to kind of encourage the clinicians to screen and sort of categorize patients, parents, as to whether if they were smoking or not. If they were smoking, were they interested in quitting? And, sort of what was their stage of change as reflected by, are you interested in quitting in the next 30 days or the next 6 months, or is it beyond that? And then based on what we were hearing from the quit line, we identified those that kind of had a proximal goal for quitting as great candidates for referral. So the quit line. So screening prompts. We had a little question mark tab where you could get a reminder about motivational interviewing principles to sort of try to deliver like a brief dose of motivating counseling for the parents. And then these tabs where you could, offer a handout to families about the risks associated with tobacco smoke exposure for children, as well as a fax referral form to the state quit line. And so what happened? Very crude Excel figure showing our referral rate. So we were able to get state data about, how often our little practice was sort of referring patients to the state quit line. So we had one referral in the 3 months before the intervention, and then we launched our intervention, and then, we had some more referrals. And so this is really exciting, not complex analysis. But, we could have stopped there and patted ourselves on the back and said, we had some progress, but we also tried to look at some EHR data about what was happening. And so we looked also at screening. So you remember our little nudge was also trying to get clinicians to screen more. And it looked like we had no impact at all on screening. So 35% of primary care visits involved screening for household smoke exposure pre, and then 36% post. It's not really a meaningful difference pre to post. And then counseling. So this was interesting. This is when, we talked about deceiving yourself, right? So we didn't have a way of really assessing if people were doing counseling before versus after. We basically were looking at indicators in the EHR of counseling and, in the documentation, but our intervention was associated with more opportunities for documentation by nature of the tool that we launched. So we saw an uptick with that, but we acknowledged in our limitations that that's highly flawed. So we don't really know if we influence counseling. So a relatively simple, easily replicable and low cost EHR modification and brief clinician training, which we accompanied the launch with some training for clinicians about principles of motivational interviewing, was associated with higher rates of counseling maybe and quit line referral for patients who smoke. Highly limited study, right? So it was a pre-post study. I didn't know about interrupted time series analysis at that time. Certainly was not a controlled study. And we were only looking at process outcomes, right? So this was, we called them process outcomes. Now I might call them implementation outcomes, some of the things that we looked at, but we were not looking at actual rates of smoking cessation among parents. We had no access to the patient experience. Did we, did the clinicians by screening in this way and offering these handouts, how did the patients feel about that, the parents? There was so much we didn't know. So question to the group. What are the questions an implementation scientist would ask next? I'm going to try to engage you guys a little bit because you've been silent. What do you think? So out of that very crude, simple study, which I might even kind of put in the category of a continued needs assessment, what are the questions you would ask next? Because you're all now kind of becoming part of the implementation science community through this workshop. Go ahead. Yes. Well, so I'm going to pause that question. Maybe we can chat about that later. Just because I have such limited time, I'm going to just keep going with the goal of asking you guys, what sorts of questions would you be asking next? What are the gaps here that you see that you might be interested in? So implementation strategy, you're interested in implementation strategies. And what's the thing? What are you thinking about as the thing that you want to kind of, what's the evidence-based practice? Is that clear? Yeah. Yes. Yes.
Change all of the time, then we achieving our goals. Yeah.
That's great. So you're kind of signaling adaptation, iteration. Our goal is to try to influence clinicians' behavior and adherence to an evidence-based practice, whether it's the screening, the referral, the counseling, kind of. And so that's exactly what we were interested in. And so we started to look to our theories, models, frameworks. And at the time, there was this great paper that has one of the most appealing titles. It says, "Why do clinicians not follow clinical practice guidelines?" ? And I just was so excited about this paper. Michael Cabana is a department chair of pediatrics in the US, and it's been so neat to tell him that this paper really inspired my career trajectory. But it was the first time I really saw someone kind of trying to almost make file folders for all the different reasons that a clinician might not follow guidelines. And so, this is just one example. There are, we now have the CFR, we have the Paris that are maybe even more comprehensive, but this is an example of thinking about how knowledge, attitudes, as well as behavioral factors all kind of influence whether or not a clinician does something that can kind of get us to better identifying barriers that may be linked to implementation strategies. I think our two commenters were signaling this, right? You want to understand why. So why did screening not change? Why did referral change? And then what can we do? What's our next step in design? So I'm going to jump to the next. This is a slide I showed yesterday, but this is another study where I think the design and the way we define our outcomes really influences what we're able to detect. So this was a pop-up alert, if you all remember from yesterday's talk, where there was a large-scale multi-center randomized clinical trial looking at whether this pop-up in the hospitalized patient setting influence care for patients with acute kidney injury. And they defined their outcomes as mortality, kind of receipt of dialysis, and progression of acute kidney injury. And so this pop-up would alert if you sort of met certain criteria. And their hope was that this simple alert would remind clinicians to do recommended care. And they sort of anticipated that that would improve these outcomes. So what actually, just a little bit more about the design. This was in 6 different hospital systems, some of which were academic and some of which were not teaching hospitals. And I'm just going to skip over this in the interest of time, but this is the punchline, right? So what did they find? Essentially no effect overall of this pop-up. But what's interesting here, and what the take home I hope you'll take away is thinking about what are the important points of potential heterogeneity of effects, right? What are the differences between your sites of implementation or your clinicians or your patients, where you think there might be some differences in whether your intervention or implementation strategy works or doesn't work. So they had the foresight to think, hey, some of these practices are teaching hospitals and some of these hospitals are non-teaching hospitals. We're curious if there's a different effect. They looked and they actually saw a substantial difference. So this, the death outcome, you'll see there's a difference. The orange bars, there was actually a higher rate of mortality associated with this pop-up alert at the non-teaching hospitals compared with the teaching hospitals. And so just a really interesting finding. So not only overall was there no effect, there's some signal that there might have been harm. So what's that all about? This is an example of an effectiveness study that was not a hybrid design. Beyond looking at this, teaching versus non-teaching, they didn't have any, formalized process of, interviewing clinicians or doing surveys with clinicians. So they don't really know. And actually one of my colleagues has proposed a new grant to actually go back and talk to clinicians and try to find out what's going on here. So we'll skip over this. I think the implementation research questions are obvious. The study designs, I think we talked about hybrid effectiveness implementation designs, mixed methods research, thinking about how can we hear from those that are being, all of the kind of stakeholders and key informants that are being affected by the implementation to understand what might be going on. And then this last study that I just wanted to share with you all was just published, and it's kind of made some waves in my field of pediatrics, which was a large-scale dissemination implementation trial that followed an effectiveness trial. So this is a study of motivational interviewing in pediatric primary care clinics to try to address childhood overweight and obesity. And the original effectiveness trial was really exciting because they showed that it worked in a controlled context where, it was real world, but they monitored fidelity. They knew that the people delivering the motivational interviewing were trained, and they sort of monitored delivery. This was the next step where they worked with a national primary care-based research network and delivered the intervention broadly. And so what happened? I think one of our commentators talked about adaptation. They had to adapt their study. They had to be able to deliver it across all of these practices. They took some of the motivational interviewing components and modified them so that it was delivered by different types of staff. It was delivered through different modalities, in person versus virtual delivery. So there were lots of adaptations that they made. And what actually happened with this dissemination implementation study, not only did it not work, you'll see they actually had worse outcomes in the intervention arm than in the control arm. And so, I think this study was a big shocker to everyone because we had just put out guidelines that the summative evidence supported motivational interviewing in pediatric obesity care. And then this came out and everyone said, well, it doesn't seem to work. But I think Luke talked about this, the concept of throwing out the baby with the bathwater, right? If we don't assess fidelity and if we don't carefully track adaptations, we might draw inaccurate conclusions, right? We might say motivational interviewing doesn't work for childhood obesity, but because they sort of went through the careful steps of a more controlled efficacy effectiveness study where they knew under high fidelity conditions, this does work. This allows us to narrow in on the adaptations and the implementation strategy as the areas where we need to focus our attention and work, right? So I just thought this was a really fascinating study that sort of drives home some of these points about not only do we assess the right outcomes, but tracking adaptations so that we know exactly what we changed. And I don't have a slide for this, but I think in Luke's talk, I believe, or someone's talk, they talked about the Sturman framework, STIRMAN framework called the FRAME. That's a model for describing adaptations. And a piece of that is thinking about, is this a fidelity consistent adaptation? Or is this a kind of a fidelity deviating adaptation? and kind of carefully thinking that through, while also tracking fidelity as an implementation outcome through the process of your trial. So if they had not done that, which, there's some, they could have even done a better job in this study, but if they had not kind of explicitly talked about that or done that, they would have really missed an opportunity with such a huge trial. So I'm going to leave it at that and actually stop the talk because I think I'm doing okay. All right, good. So are we transitioning to? Okay, no, this is, I think we're good. I zipped through the early parts. So.
Great, thank you.
Okay.
No, thank you so much.